Well, welcome everyone. Today is August 16th, 2021. We are recording a show for a month from now, September 15th. I'm Trey Dobson, Chief Medical Officer at Southwestern Vermont Medical Center and an emergency medicine physician with Dartmouth-Hitchcock Health. And this is Medical Matters Weekly, a show about the aspects of healthcare that matter to you most. My guest today is Dr. Vikas Saini, the president of the Lown Institute, which ranks hospitals based on social responsibility. A little bit about Dr. Saini. He's a cardiologist by training. He studied with Dr. Bernard Lown, the Lown Institute's founder at Harvard. He's the co-chair of the Right Care Alliance, and then on a list of accomplishments. He's an expert in optimal medical management of cardiology conditions, medical overuse, hospital performance, and health equity. So thank you so much for being on the show.
My pleasure. Thanks for having me.
And just for our audience, where do you live right now?
I live in Cambridge, Massachusetts, and right near Fresh Pond, if anybody knows where that is.
Right. And then you mentioned you were just up in Vermont over the weekend, which I think is awesome.
I was. My wife and I went up to the Northeast Kingdom and spent a little time up there. We really enjoyed it. We got very lucky with the weather after the heat wave.
Yes.
And then picked up my daughter from camp. She'd been at Kill Elite for 7 weeks straight. So.
Wow, that's great.
Yeah.
And did they do okay through COVID?
Remarkably well. I think they were testing once a week, but everybody was negative when they walked in, and they didn't have a case. So
that's great.
Yeah, that was.
So
great.
Tell us a little bit about how you first became interested in medicine and cardiology specifically.
Sure. Well, there's I could go on about that. In terms of medicine, in retrospect, as is often the case as we get older, I recognize there were motivations that were unconscious at the time. But my father had wanted to be a doctor and couldn't afford to. He grew up too poor. The family lost it all in the Depression. Mm-hmm. And, I was a bright kid, and he kind of encouraged me. And being rebellious, I said, no way, no how. I really wasn't going to do this. Right. And then I took a year off from college, and I traveled. I went to Europe, and I went to India. And, I traveled by buses and trains and saw huge swaths of the world, really. And the thing that struck me the most was how much desperate need there was. And, I had often thought about social ideas and social practices, and I was interested in economics and politics and this and that. But really, on that trip, I recognized that it's really hard to beat the good you can do one-on-one in the exam room. And that there was just something about that was fundamental, and there was such a need. So I came back from that year off, and I announced, much to my father's delight, that I was going to apply to medical school. So.
Oh, that's great. And then you did that, and you got into medicine and started focusing on all of the learning and struggles that you have to go through. But at some point, you saw that there was an opportunity or a need for improvement in the way that hospitals operate. Can you talk a little bit about that for the audience?
Sure. I mean, I think I'd have to start first by how I actually got to Boston to work with Dr. Lown, because I did medicine. I was at Johns Hopkins, and there I was kind of dazzled by the chief of cardiology and by the nature of the care and the intensity of it. I like to say I was taken in by maybe all the wrong things, by the devices, the drama, all this kind of stuff.
Sure.
As a young man, and I loved it. I was not. In fact, I traded out of other rotations so I could be in the coronary care unit, and that was every other night. So I had like 6 months of every other night, but I loved it. And then I decided to do cardiology based on all that, and came to Boston to work with Dr. Lown. And I didn't know that much about him other than he was a revered figure. He'd helped develop the defibrillator. He had kind of written the book on arrhythmias and sudden cardiac death, and was just a giant figure. I knew that. What I didn't know was how much of an iconoclast he was, and in particular, by the time I got there, he had a firm view that there was way too much bypass surgery, and then eventually stenting came along. And so he had a view of the world, and the motto really that he imparted on all his trainees was, do as much as possible for the patient and as little as possible to the patient.
Wow.
And so that kind of ethic, it's like how it is when you grow up with something like that. I wasn't really aware of how unique it was until I went out into practice, and then I saw that it, practices vary widely. And of course, people at Dartmouth would recognize that Jack Wenberg and Ella Fisher and everybody up there pioneered this work to show that that is really true, and that a lot of that variation is really not based on evidence or what we know. And so I think when I recognized that and saw how much variation there was, I got involved with trying to find pathways of care that were a little more efficient, that were, didn't take up as many resources, that didn't subject patients to as much risk. And so on all those grounds, I got very interested in the kind of workings of medicine. And so I actually started a primary care network, and we took insurance contracts and started understanding how to manage care with an eye on how, what's necessary and what's unnecessary. So that's what got me really deeply involved, and I started understanding how hospitals work better, how, doctors and outpatient and home health and all of that started working. And I started understanding the business side of that too. So I had a good sense of how the system works. So when Dr. Lown kind of persuaded me to come back to Boston, I was in practice on Cape Cod. He persuaded me to come back to Boston and lead the Institute. It's kind of natural to start doing work in this area, but I would say it was a slow start. It was a very slow ramp up.
Right. So for the audience here, there's many people who know exactly what you're talking about, and then there's others that are saying, wait a minute, I'm not following. And what we're talking about here is variations in practice, whether that's individual types of practice, departments, or entire health systems that often vary by region. Dartmouth, Hitchcock, and many others have started bringing that out through review of data from the Centers for Medicare and Medicaid Services and other data sources, and then started looking at the outcomes. Do the outcomes match the amount of things, as you said, are done to a patient? And in fact, they don't match. If anything, they're inverted in that type of relationship. And but many people have read about that. They've read Atul Gawande's and other articles on that. It is fascinating as we try to recognize that things like standardization really do lead to reliability, and controlled innovation is how we're going to improve outcomes, but that has to be done in a controlled manner. And your organization, Lown, starts to point that out as far as what hospitals do and how they vary. And you come up with this hospital index. Can you talk about that some?
Sure, absolutely. We decided that it would be useful to begin looking at hospitals and performance of hospitals through a different lens. We're aware of the U.S. Everybody's heard of the U.S. News rankings. There are other rankings. IBM does one. Leapfrog has them. And so the last thing the world needed was another ranking. So we weren't sure how we'd be received, but we did feel that there was a lot that was being left on the table. And amongst those things was this understanding that, there is variability in care, and that some places and some physicians and some hospitals, will have a lot less unnecessary care. Others will have more. We also recognized, and one thing I shared with Dr. Lown really was a very broad view of medicine, how medicine fits in with our society as a whole, how health fits in with our society as a whole. And so, we recognize that there's so many variables that go into good outcomes. There's all the stuff that happens way before the hospitalization. Many people talk these days about a term called social determinants of health. And really, that's just a recognition, which has now been proven many times over, that the vast majority of our life expectancy and our health and healthiness is unrelated to medical care, is unrelated to hospital care. And it's really related to things that happen way before, things like nutrition, prevention, exercise, things everyone will have heard about. So we knew that that was part of the mix, but we also knew there are other factors like equity, like the ability and inability to get access to care, affordability, like the ability and inability to have health insurance. So Dr. Lown had a broad view, and I share that view. And so what we wanted to do was develop an index that would reflect that. So we did that, and we included a number of metrics that are quite novel, really the first time they've been used. And, we continue to do that work. We update it every year. And our goal and our hope is that as more and more people begin to understand the value of that point of view, more and more people will embrace it and begin to, create opportunities for improvement in each of those dimensions.
So I have to say a plug that Southwestern Vermont Medical Center was very proud to rank 4th in the nation for value of care in 2020. How would you describe what we at SVMC and other hospitals that rank high are doing well?
Well, I wish I had a pat answer. I mean, I've been interviewed enough that I ought to have one, but I don't. And I think this is a truism of healthcare, that while there are patterns and you can make statements that are general, almost every situation is different. Those of us who are doctors know every patient is unique, and you can't apply a cookbook to a patient. It's the same thing with hospitals. But I will say that New England in general did quite well on this issue. So this one particular metric of value, and in particular avoiding unnecessary care. We actually published a paper in one of the Journal of the American Medical Association journals. And in that paper, we found that New England does very well. Why is an interesting question. I think the medical culture is a little more conservative. I think there has been a longer tradition of a little more scrutiny or regulation. And I think, as Dartmouth researchers have shown, culture sort of propagates. Where you train and how you learn how to practice stays with you. And so I think that's probably a big factor. What we've seen is that for many of these procedures, there are occasions when they're appropriate, and most of the time they're not. And those are the ones that we reported. We just simply counted them, and we counted them, at every hospital. And then we did an assessment, sort of normalized everything mathematically so you could do apples to apples. And so I don't actually know the answer about your institution. I mean, it's the kind of thing where you kind of have to come and walk the halls and better understand it. Right. You probably have more to tell me about that than I can tell you, actually.
Well, I will elaborate a little bit on some of the cultural aspects. I think most any physician, around the country, no matter where they live, New England or not, wishes, of course, to do the right thing, to minimize harm and focus on what they want to do, which is limit suffering, right? Not order tests. They want to limit suffering. But they do have, in a sense, they're sort of held to the standard of the region and what others are doing in that region. And I face this all the time myself, every day that I practice. The day that I don't face problems is the day I should retire, right? And so I struggle with the person in front of me, but really it's not making changes on the fly for the patient in front of you. It's making those changes as a system so that what's expected is more uniform in that way. And then I'll give an example. If we went out and told people, look, I'll just use the classic example that Dr. Gawande and others have focused on, echocardiograms in young people with chest pain and very low risk of having acute coronary syndrome or heart attacks. If we said, look, just don't do that, well, that doesn't really work very well. The person in front of you is suffering and you're trying to do the right thing for them. But if we say collectively, we're going to put in preventative measures that make it where that's not the path of least resistance. In fact, that you have to prove something beyond in order to get a particular type of study, then, and again, that was just an example I used, then it helps me when I have a conversation with a patient. It helps my colleagues understand how we're practicing, and then we measure those. But boy, it is anxiety provoking if you're a doctor or another type of healthcare worker, a technologist, a nurse, and the patient's in front of you and you're trying to explain why you're not going to do something, and you start talking over yourself and realizing this is not what we're trying to do. We're not trying to change this particular encounter. We're trying to change and motivate large system efficiencies, so that we reduce cost and improve outcomes.
Yeah. Well, I couldn't agree more. I mean, and at the end of the day, I think one of the most important things that I learned from Dr. Lown about all this is really that, people want to be cared for. I mean, people don't particularly come in. I mean, nowadays with the internet, they kind of do, so I get it. But they don't usually come in saying, I want this test and this test and this test. They come in with a problem or a concern, and they want to be taken care of, and they want to be taken care of professionally, and they want to be taken care of knowing that all the right things are being done. And, there's a risk of harm when you do stuff that isn't necessary. So it takes a dialogue. And I will say the emergency room is one of the hardest places because it's very transient. Relationships, especially long-term, longitudinal relationships, really matter in healthcare. They really make a difference, because when I know somebody and I know someone well, I know their history well, I know their family situation, I know their social situation. When they come in with a complaint, I have a good sense of whether this is a very weird thing that better be thought through and looked at carefully and no stone left unturned, or whether this is, it's again one of those stressful times, and that wayward son is home and all the stuff is going down, and
right.
And so I think relationship-based care is a fundamental part of this, and sadly our healthcare system isn't really structured properly for that. That's my personal opinion. There's lots that we could do differently and do better. And that's why we started looking at these broader systemic metrics. So we include metrics of what we called civic leadership last year, and this year we're calling equity. That includes racial inclusivity, that includes community benefit investments that hospitals make. That also includes things like pay equity, just trying to understand how workers in hospital settings are doing. And this year we're also looking, in addition to avoiding overuse, we're looking at something we're calling cost efficiency, which sounds like a sort of bean counter thing, but it really is important, I think, to understand if we can get the same outcomes, we can get really great mortality, with much less trouble, with fewer kind of unnecessary things being done. That's a net positive for all of us. And of course, we do look at mortality, we look at readmissions. Those are kind of the standard things. So
right. For the audience, just all of the outcome variables, again, to reiterate, don't align with the amount of tests and things that are done. So can you just give us an example or a few of what is considered, and I don't even like this term, but it is the most appropriate, probably, hospital overuse?
Well, we looked at a lot of research literature, and in the last 10 years, in particular, there's been a lot of research on this. And there are a lot of things, a lot of tests and procedures that are not indicated or no longer indicated because of new evidence and science. And then there's a lot of procedures in the gray zone where they're indicated for some people, but not for others. And it all depends on the clinical circumstance. So we took great care not to have those in what we counted. So we looked at the stuff that is literally pretty much accepted that, it's really not indicated in the way, it's done. And then we spent a lot of time coding to be sure the inclusion criteria and the exclusion criteria were good enough to reflect that. And then we had a group of us who've been in this area, doing research in this area for, the past decade, pick 12 services that are more hospital-based. There are quite a few that are, in the outpatient setting, but only the ones that were hospital-based. And those are the ones we then counted up. We used claims data from Medicare, and we counted those up. And there are things like arthroscopic knee surgery as opposed to just knee arthroscopy. It's certain types of vertebroplasty, certain types of spinal fusion. In my field of cardiology, stenting of coronary arteries when the condition is quite stable, and there are others like that. So that's how we kind of picked a few. There's probably a lot more, as you know, as a clinician, there's probably a lot more areas where we could do better. But those are in the gray zone where it takes a lot more understanding of the clinical picture. So it's really hard just from databases to figure that out. So we did not go there. And I think that's a whole other conversation. Like, how do we develop those methods and tools to figure that out?
Right. So part of that is actually supporting the physicians through these decisions. I'm sure you see this all the time, but people get defensive when you start talking about, again, that word overuse or misuse. And as an emergency physician, even what I love to do, which is focus on this stuff, I can still get a little defensive because in my head, the people that are talking about this aren't seeing the pressures that I'm seeing. And so really what it is supporting us through that these decisions are the right thing to do and that patients understand that, and that most of the time, a vast, vast majority of the time, it will work out well and in favor of the patient. Of course, we can't practice for these one-off rare things or we're not going to be able to afford that in healthcare. Plus, as you said, we do harm patients.
I mean, one of the problems is the harms are often invisible in the sense that we know there's a risk from any test or procedure. It's a small risk most of the time, but it's a risk. And if the procedure's totally indicated, then that complication or that harm, as unfortunate as it will be, and as much regret as we may have, we kind of have to say, well, we knew there was a risk and we took that chance, and sadly this is how it turned out.
Yeah.
And the problem is those events are rare, and if you have a case where it really wasn't particularly necessary to do the test and there's a harm, it's not easy to connect those dots. And so while we know there are these harms, we can't connect the dots on any given case. Or let me put it this way, the cases where we can are very, very rare. But the ones where we can are kind of can be quite shocking. I mean, there's a famous one that was published in the Journal of the American Medical Association about a young woman with chest pain who, in the end, probably really shouldn't have had a cardiac cath, but she did, and there was a tear on her left anterior descending artery and a massive heart attack. So much so she ended up needing not just surgery, a heart transplant. So, I mean, that stuff, that's an anecdote. It's only one, thank God, but it sort of tells you that, we're probably not looking and we may not be seeing. So it's incumbent on us to just practice, the best we can. And I think, there's a sort of ethic of parsimony, which is what, that motto of Dr. Lown's really reflects. Do as much as possible for, as little as possible to. So.
Yeah. I have one of those that I learned a long time ago, and now my memory is faded, and I'm not sure how real it was. In my head, it was a friend of mine, but This was someone practicing pediatrics in a rural part of another country, and the child he diagnosed with Kawasaki's disease, and then the child improved and was fine. And so he sent them 3 hours away to the tertiary care center to get an echocardiogram, because you do that after Kawasaki's, because you can develop these coronary aneurysms. So the family came back a few weeks later, and he said, "I'm so sorry, I don't have the report of the echo. I'm just going to have to call up and see what the results were." And they said, "Oh no, they wouldn't do it." And he said, "What do you mean they didn't do it? I ordered it." And they said, "Yeah, well, they said it's not indicated." And so he said, "Well, 5% of children with Kawasaki's get coronary aneurysms." And they replied, "Yes, and only a very few percent of that 5% need anything done about it to begin with." So I don't even know how true that is anymore. I just thought it was a illustrative, really interesting story. And she said, by the way, on the way to this academic center, our car broke down. We incurred a lot of expenses, and it's not near as bad as the heart transplant story you were telling, but it does show that our decisions there do have consequences that may be unintended. And so, we need to practice in that way. Tell me, what does success look like from your perspective and from the Lown Institute?
Well, I think for us, we feel that the role of the hospital can be and really must be part of a general transformation of our healthcare delivery system. Our system is famously incredibly expensive compared to much of the world. The prices are pretty high. And I don't think, there is some unnecessary care. Obviously, we've been talking about it, but I don't think that's why, these other issues are there. We think there's issues of equity. We think there's a lot that can be done. So for us, we also don't pretend that there's simple solutions. Now, I personally favor, some kind of a single payer system, and I think there are flavors of that. We have barely begun to really understand that and explore what the different flavors of single payer could be. But that's an example. It's not the whole story by any means. It's just one example. There's so many dimensions of how we need to improve things so that healthcare is much more responsive to local communities, more accountable to local communities and families, and really highly efficient. That the sort of the best possible outcomes and the best possible quality with the least possible expenditure of resources, because we really need to be careful with how we spend our time and our money in order to be sure that everything we need to do in the country gets done. And increasingly, at least the way I look at it, a lot of that is going to be taken up with issues of climate and climate change. So we have to really make our healthcare system, really sleek, like a super sports car that's just fast, very efficient, very good. And honestly, there's no reason in the world that families and patients shouldn't walk away from their encounters day in and day out feeling like it's just the best damn system in the world. But it's not. It doesn't happen often enough. And I probably don't need to tell you the level of fragmentation and missed, dropped connections and all these different dimensions. And it doesn't seem to be getting better. So we do need a transformation. And our goal with this project is simply, as I said, to get that conversation started, get more people engaged, get more people interested in things that are a little more than the kind of reputational rankings that generally are what the media tends to cover.
Well, I tell you, I really appreciate what you had to say about recognizing that the solutions are complex themselves. There's so much when we have this topic. I think one of the reasons people get feel defensive is because there's often a lot of finger pointing. It's the emergency physician's fault. It's It's the freestanding clinics in the South's fault. It's, pointing fingers rather than saying it's not that. There are many, many variables involved, and it's going to take time and cohesion to really improve the system, which I think we all want. And that leads to some being optimistic, as you were there at the end, that we will improve the system.
Yeah, well, I think we can. And I think there are, different parts of the elephant that everybody kind of describes. What we haven't yet really had is a really hard, focused, determined, and sustained effort to really integrate it all into a common approach. So, for example, when I talk about single payer, I favor single payer, but with a different payment structure than fee for service. And there's a range of things you can talk about technically. I also think there's no reason in the world that a lot of what patients and families experience couldn't be improved dramatically in ways that would make physicians, for example, even more satisfied and more delighted with their work. And we know for sure that ain't so these days.
That's right. Well, we will end there. Thank you so much for joining us today on Medical Matters Weekly. We really appreciate it.
My pleasure. Thanks again for having me.
Absolutely. And you can find information on the web about the Lown Institute. I'm also going to thank Cat TV, Ray Smith from Southwestern Vermont Healthcare, Ashley Jowett from Southwestern Vermont Healthcare. I'm Trey Dobson. Go out and find joy in everything you do, even in the face of adversity, and we will see you again next week.